this evening, and this is a very important and momentous occasion. The launch of Handbook of Cancer Chemotherapy. Every oncologist has been keeping, I have been seeing for last so many years in the pocket. This has been very important assets to follow. And I am welcoming all of you in the hall and delegates from so many countries and online. I guess more than 600 people are there online. I'll keep you updated on that. With that, I would like to invite our chairpersons for the evening, Dr. Rajiv Agarwal. Dr. Agarwal is Senior Director, Breast Services at Medanta Hospital, Gurgaon. And Dr. Sandeep Batra, Director, Cancer Care, Max Super Specialty Hospital, Saket, Delhi. I request sir to introduce next speaker. Thank you.
Good evening, everyone. Congratulations. Being started with the CME and have with us so I invite Dr. Randeep to present his talk. Thank you.
Thank you, Sandeep, and congratulations to Vad sir, and my regards to all my seniors, and I really consider it a privilege, and talking about a vast topic, especially in front of people like Lalit sir and Vad sir, it is a privilege. It is another 20-25 minutes. I will try to do a justice to this topic. Couple of medical oncologists are there in the house, and they will realize that it is very difficult for a person to, any medical oncologist especially, to cover a topic like HER2 positive breast cancer. Is it a problem of Western world or it is Indian problem? Of course, it is a problem among our continent. Of course, the variations have been there in various studies. But if you see on this slide, at least 1/5 to 1/4 of your of any center or any part of India where you practice, you will see HER2 positive breast cancers, and we see both early, locally advanced and metastatic breast cancer. So I thought in next 20-25 minutes, how we have started treating in last couple of years, what changes the science has brought, and how much it has helped our patients as well as us, we will discuss that. So in a very brief, HER2 can be targeted in 2 or 3 ways. And first is that HER2 is a transmembrane receptor, as we all know. The extracellular part of the receptor can be targeted by monoclonal antibodies, and we have with us trastuzumab and pertuzumab for more than a decade now. What new, and TDM1 for less than a decade. And what new is happening is the development of ADCs, which you can see on the right hand side of the cartoon. And that is where these antibody drug conjugates act, and one of them which has been recently available to us is TDX, or that also acts on the extracellular domain. Now the other molecules are also there, lapatinib, neratinib and tucatinib, with lapatinib available to the Indian oncologist, which acts on the inner side of the receptor, and both of them does help to block this pathway which helps in proliferation of cancer. So this is how we have been targeting HER2, and this is in a nutshell where the science has worked. How TDX and TDM1 are different, because both of them are antibody drug conjugate, and to a person who is not aware, they will think that TDX and TDM1 both are antibody drug conjugates. But if you see this slide, they are actually very different molecules. The TDX has a selective cleavable linker, and that linker is shown light blue in this cartoon, and that gets degraded when there is an internalization of the TDX. And then the other special part of it is called as the bystander effect, which was not seen in TDM1, is that when this payload gets cleaved from the antibody drug conjugate or from the trastuzumab part of it, then it can cause bystander effect or effect on the adjacent cells which are not expressing HER2. And that is why this drug has been worked as well as approved in in HER2 low breast cancer, but we are not discussing HER2 low here because today we are just focusing on a classical HER2. For the students, if there are any, the HER2 low is when you are HER2 2 plus and FISH negative, or even HER2 1 plus and FISH negative. But HER2 low disease is definitely a very different entity which has evolved in next 2 to 3 years. And in today's this discussion, we are not covering HER2 low CA breast. So for starting from 1998, I think 2 decades have gone by. Every time as a medical oncologist, I think me or my other colleagues used to think that yes, there will be a full stop. But if you see this line, this is going on and on. I mean, when trastuzumab came, we were very happy. Then pertuzumab came. Then TDM1 came, and we thought it is the end of this. We have already exploited, and this pathway is exhausted. But if you can see lately, especially in last 2 years, the space has become more crowded, and this has really crossed the expectations of a non-researcher clinical oncologist like me. And recently tucatinib, neratinib, margetuximab, which is another monoclonal antibody, and TDX have really got approvals, and we will see with few slides that it is not only the science, it is also bringing benefit to the patients. So building on trastuzumab, I will not cover trastuzumab as we are all aware. What I thought in this slide, we see that we all are aware that 5-year survival will be around 68-70%. But if you see this carefully, so there will be 60% of the patients will be cured by chemotherapy, and there will be another 30% who will need more treatment. That in spite of trastuzumab, and this is the 11-year follow-up of HERA trial. And if you see there, that the red curve is there where you need escalation, and then there is another 60% which as a medical oncologist we usually forget because it is slightly pharma-driven branch. We usually forget that always as a medical oncologist we need to also look upon those 60% of the patients which can be de-escalated, and we can avoid financial toxicity to these patients. So I will start with de-escalation approach. Patients who have early breast cancer, and we are now talking about non-metastatic breast cancers, we have APT trial, and we have this trial since last a decade, but the last follow-up is very assuring. This was a 10-year DFS data published in Lancet 2023. We all know it as Sara Tolani trial, very famous, also called as Tolanili trial or APT trial. We have de-escalated the chemotherapy here, but if you see the blue bars, we have not de-escalated the trastuzumab. So when you are practicing, please de-escalate either chemotherapy or either trastuzumab duration. Don't be too optimistic and de-escalate both the chemotherapy and trastuzumab duration. Also another point which we often discuss, that though we say that 3 centimeter patients, that the patients had an inclusion criteria of till 3 centimeter, but if you see the 3 centimeter patients tumor were less than 10%, so practically this curve of 10-year IDFS of 90% plus applies to 0.5 to 2%, and anyone as the size goes on increasing from 2.2, 2.4 or 3 centimeter, I will be uncomfortable in using APT regimen. Another de-escalation which we talk very less, and I don't know why we have not adapted this, is a non-chemotherapy approach, and this is also known as attempt trial, where TDM1 has been compared to the APT trial. APT trial was a weekly paclitaxel with trastuzumab regimen, the one which has been shown in the previous slide. In the APT trial, that was the experimental arm, but since APT became standard, in the attempt trial, this was considered, the weekly pacli and trastuzumab was considered as the standard arm, and that was compared to TDM1, or we also called as non-chemo approach. And if you see the 5-year IDFS is absolutely 97%. This was a phase 2 trial. That's why you are seeing a single curve here and you are not seeing the comparison or. But with TDM1, a 5-year IDFS of 97%, definitely let us think, and this is absolutely a valid approach. What has not been shown in this slide is the toxicity. TDM1, whenever you use in the adjuvant setting, the toxicity is more. Most of us who have used Catherine dataset in the adjuvant TDM1 will realize that there has been discontinuation rate. Even in the affinity trial, there was a 30-35% discontinuation rate of adjuvant TDM1, and similarly 30 to 35% of the patients could not finish TDM1 in the attempt trial. So the TDM1 which we use in metastatic setting slightly becomes toxic when we talk about adjuvant setting. This is what is hidden pearls in oncology we never know. that when we change the setting, the toxicity changes of the drug. The other de-escalation strategy is reducing trastuzumab duration. As a standard, we don't tend to do it because of mixed results. The only trial which has been positive among many non-inferiority phase 3 trials conducted in last 5 to 7 years or more is Persephone trial, where the non-inferiority was proven as 1.29 was the non-inferiority margin, and if you see the confidence interval was 0.93 to 1.24, and this was within the boundaries of non-inferiority. But there has been other trials which make us think that whether we reduce the trastuzumab duration. As a standard practice, I don't adopt to reduce trastuzumab duration to 6 months, but in someone who is elderly, someone who is having say 2.5 centimeter node negative disease, one node positive, hormone positive, and these are all off protocol indications, and this is how we use our wisdom, I am okay. And someone who is really having constraints, though the chances of having constraints of anti-HER2 therapy are decreasing every year, and with the advent of biosimilars, this has really become less. But yes, in a subset of an elderly patient to reduce cardiac toxicity, and in a patient who has financial constraints, I am okay to give 6 months, provided the tumor size is within 3 centimeter, it is hormone positive, node negative. Now, de-escalation part was the first which I thought I will discuss. Now we go to escalation, and we have plethora and floods of pharma trial and escalation strategies. The first is affinity trial. Now in affinity trial, what happened was, which we very rarely see in the practice because of MDT approach, is that in affinity all the patients who were having more than 2 centimeter or node positive were taken, and then they were done, the surgery happened, and then they were subjected to dual anti-HER2 therapy. Now in a proper MDT setting, we will have very less patients who are having a locally advanced breast cancer. I mean, someone who is having a node positive and has passed through genuine MDT will not be eligible for affinity. But we are human beings, we practice in different ways, so we do get patients for affinity from our surgical colleagues sometimes. And sometimes it is, I will not blame the surgical, sometimes they think that it is a node negative and you have surprises that you operate and then suddenly you have 5, 7, 10 nodes positive. Whenever you have a node positive disease, as per affinity and approvals, we have to use a dual HER2 therapy. And why I am saying with this confidence is that in a node negative, you see the disease-free survival advantage is delta -1. But the moment you see for node positive, there is a delta of 4.9%. And the OS is not very assuring, but 1.9% is the OS. So don't push your patients very hard if they are having a difficulty in their pocket. But someone who can afford it, I think adjuvant trastuzumab and pertuzumab for a node positive breast cancer makes some sense as per the science. But if someone is taking only trastuzumab with 1 or 2 node positive, we shall try to counsel them and not make them feel guilty that if they are not able to take pertuzumab, then they are definitely losing on something. And see, some things I'm adding with my wisdom that this is how science practice, and because that is the theme of the meeting, and that's why there are some off-protocol statements here, and please pardon me for that. There are many other things which have happened. We all know that if you are not achieving a pathological CR, you can use adjuvant TDM1 for a year, and you get an IDFS of delta 9 to 10%. Trastuzumab, pertuzumab was the affinity which got approval, and neratinib has got approval as an extended HER2 therapy. That is, if you have finished 1 year of adjuvant HER2, then you can give 1 year of neratinib, and neratinib works best in patients who are having hormone positive breast cancer. In the interest of time, I am not discussing these trials, but these are all escalation strategies, and I think among the Indian oncologists, we have been using these strategies in quite a number of patients. With neratinib not being available, there is a limited usage and limited experience. How the way we treat will change is this slide. The TDX drug is already approved for hormone positive. I'm sorry, just. The TDX drug is already approved in the metastatic settings, and DB11, I am aware, is being conducted in a couple of centers in India, and DB05 is also there, where we are using adjuvant TDX, and this is what will change. Also in DB11, if you are not achieving pathological CR, and what we did in Catherine was that these all patients went on to TDM1. they are what doing now in DB11, they are using TDX as NACT versus they are comparing it with Paclitaxel, trastuzumab and pertuzumab, and then surgery and then pathological CR is the primary endpoint. So I think in another 4-5 years, when we discuss about this field, it will definitely change further. Also, we have fixed dose subcutaneous preparation available, and this is a phase 3 non-inferiority trial where a fixed dose combination of pertuzumab and trastuzumab, which is I think for almost around 2 years, is available to us in our country. And there is a science behind it that if you use it as a non-inferiority, they have shown that the plasma levels are maintained. And yes, and then there is a couple of data set that the cost reduces. And definitely in the initial phases when I have used subcutaneous pertuzumab and trastuzumab, I had my reservations. But believe me, the 20 ml of volume loading goes as smooth and definitely goes without any toxicity. Definitely the first preparation has to be monitored and it has to go slow. But subcutaneous pertuzumab and trastuzumab in the adjuvant settings as well as in the metastatic setting is gradually filling up the gap and reducing the burden of the patients for the administration in the private hospitals where the bed cost is definitely higher. And it also gives an advantage of conventional pertuzumab and trastuzumab. And with my experience, I think toxicity is very, very minimal. And we have used in around 25-30 patients, and then in 30 patients, many cycles have gone by. So the tolerability has been fair. Shifting to metastatic breast cancer, and I will skip this slide. We already know trastuzumab was approved and by Dennis Lemon et al., and it has been over years we have been using. What changed, it is also now a decade, what changed in Cleopatra was that trastuzumab was compared to a doublet regimen in metastatic settings in a phase 3 trial. And nothing new, but yes, the follow-ups keep on coming, and the last follow-up is in 2020. If the advantage is to the tune of 16% in the PFS and around 37% advantage in the OS, with a median OS of 57 months, which makes it more than around 5 years. And so you have patients who are living, 50% of the patients will be living till 5 years, and definitely this regimen has become the standard world over. It does not add much to toxicity, but yes, if you use it, you will have to watch for diarrhea and neutropenia. These are two side effects which we don't expect when we add another antibody drug conjugate. But when you give pertuzumab and trastuzumab in combinations, keep a watch on diarrhea and neutropenias. The second line metastatic breast cancer after the patient progresses on trastuzumab, pertuzumab was TDM1, because in Emilia trial it was shown that TDM1 is a better regimen than Caplab. This was again a phase 3 trial. There was a 5-month absolute overall survival advantage with slightly having more toxicity in Caplab, and we all know that Caplab toxicity is mainly GI, whereas TDM1 is easily tolerated. Whenever you are giving TDM1, you have to watch for liver functions, thrombocytopenias, and very, very less chances of ejection fraction dipping down. And what has happened in new frontiers is two drugs, the trastuzumab duroxetan. It has been tried in second line setting as well as third line setting, both phase 3 randomized trials. As I have shown already, the Emilia trial where TDM1 was the second line standard drug after the patient progresses on trastuzumab pertuzumab combination. In trastuzumab duroxetan, the TDM1 was compared with TDX, and the second drug was HER2 CLIMB trial. Both of them are very well planned trial, but here the combination of tucatinib, trastuzumab and capecitabine was compared to trastuzumab and capecitabine in those patients who have already progressed on trastuzumab, pertuzumab and TDM1. So this is basically a third line trial. What is special about this trial is that almost 40% of the patients were having CNS metastasis, few active and few inactive. To make it short, I have coupled the primary endpoint was PFS. You can easily see, we sometimes say finger, you can keep 2-3 fingers and hand in between, especially the HER2 CLIMB trial, as well as in DB03. I am sorry, there is the HER2 CLIMB is, yes, fine. The HER2 CLIMB is the lower one, please. The right side is the HER2 CLIMB and the left top is the TDX trial. The primary endpoint was PFS. The hazard ratio is 0.33 in the TDX arm, as well as the hazard ratio is 0.6 in the HER2 CLIMB arm. Not only PFS, the OS delta is clinically meaningful. If you see the TDX, there is a delta of 10% in the overall survival, as well as in the tucatinib combination also the delta is 10%. And both these trials have really changed the way we treat our second line and third line patients. And especially with the trastuzumab deruxtecan being available in last 1 month, it will be the preferred second line or maybe the third line drug regimen. The drug comes with toxicities. Tucatinib has lot of diarrhea and hand-foot syndromes, especially when you use a combination with capecitabine, and we all know that capecitabine also causes diarrhea and hand-foot syndrome. Similarly, the TDX trial, the toxicities are mainly cytopenias, but if you focus on the grade 3, which is the second column in between, there are hardly numbers in double digit except neutropenias, and the febrile neutropenias are still very less, except 16% of neutropenia. Majority of the toxicities are less. What is to be remembered when we are using TDX is interstitial lung disease, because this is a side effect which can be fatal. When you use these drugs, you have already seen that their median PFS is way beyond the standard arms. So you're using, these patients will be on these drugs for a longer period of time. For example, if I'm using TDM1 versus TDX, there will be 8-10 month difference, and the patients, when they are longer on the newer drugs, they have more toxicities. ILD is one thing which can be toxic, and once you have a grade 2 toxicity, you have to stop the drug. That is the severity. And please keep your pulmonologist beside and always do pulmonary function test and DLCO. Initially, the ILD, when the data evolved, was around 8-9%, but as the patients remained more on these drugs, the ILD was around 15%. And these were the adjusted ILDs with TDX, though there were no grade 5 toxicities, but you have to be really keep a watch, because many times we don't keep a record, but patients do have some toxicities when they are already on trastuzumab, TDM1. They have some mild ILDs which you don't pick up. So whenever we do PET scans, keep a watch on your ILDs, and while you are on TDX, keep on repeating PFTs. Both these drugs are also active in CNS, because CNS is definitely our concern when the patients are living longer. If you see this slide of the same data set of DB03, the progressive disease is 2.8%, and we are talking about heavily pretreated patients here. So those who believe that TDX doesn't work in brain, it does work. And the other, we all know that tucatinib triplet combination is a wonder drug. If you see the patients who have active brain metastasis, the median overall survival is 20 versus 11.6 months. So there is almost a doubling of the median overall survival in patients who have active brain mets. So both these combinations in the second and later lines of therapy will also work in the brain, and you can definitely delay, if possible, your radiation therapy to these patients, especially if you have multiple asymptomatic small brain mets. There are other trials. In the interest of time, Nala trial was there. It came earlier, so we were very excited. But if you see when I have shown you the data set of TDX and HER2 climber tucatinib, this looks that this drug is not working. The Nala trial data set came earlier, and then later on we had the data set of TDX and DB03 and HER2 climb. So at that time, the PFS of 2.2, 2.3 month is what is there in Nala trial, and doesn't look to be that this data set is very encouraging. Just to complete the result, we also have margetuximab chemotherapy, which is again approved in more than 2 lines, but majority of these patients received in 3rd and 4th line. But again, the delta is only of 0.9 month. But yes, in a state where you have already used trastuzumab, pertuzumab, TDM1, which was the inclusion criteria of SOFIA, I think now we will be subjecting these patients to TDX and tucatinib. So there will be very few patients who may actually go on margetuximab or SOFIA trial. So with this, I will summarize. These are evolving algorithms. In a non-metastatic setting, someone who is having less than 2 centimeter tumor shall be operated upfront, and then if they have a node negative, they shall go on an APT abbreviated regimen with an abbreviated chemo. If after surgery they have more than 2 centimeter or node positive, they shall go on a dual trastuzumab pertuzumab combination. If at diagnosis you have a locally advanced breast cancer, or to be precise, more than 2 centimeter and node positive breast cancer, HER2, irrespective of their ER/PR status, they will be subjected to neoadjuvant treatment. Majority of us, if there are no financial challenges, we will be putting them on a dual trastuzumab, pertuzumab and chemo. We will assess them for pathological CR, and if the pathological CR is not achieved, they will go to adjuvant TDM1, that is Catherine trial, And if pathological CR is achieved after dual anti-HER2 therapy, they may just complete trastuzumab for 1 year. And believe me, I mean, my seniors are sitting here, they will agree that this algorithm, they must have seen changing it every 3 years, not even every 5 years, every decade. Metastatic breast cancer has become more interesting. We were very happy with taxane, trastuzumab, pertuzumab. After that, the complete algorithm has changed. It will go to trastuzumab duroxetine or maybe tucatinib, trastuzumab, capecitabine in active CNS disease. This is a proposed algorithm. That does not mean that in the second line you cannot use TDX for HER2 positive brain mets patient. Once you have subjected them to TDX, the next best is tucatinib, and when you have subjected them to tucatinib, the next best is TDX. Then it is TDM1, and then I think by the time we adapt this algorithm will change, and that's why that blue slide where other drugs are there, I will leave it there. So with this, I think this is a slide which is from very old presentation. I think as we grow old, we change the way we live, we change the way we eat, and definitely we are changing our way of how we are treating our HER2 positive breast cancers. Thank you for your patient listening. Thanks.
So, thank you, Randeep. This proves that world gathers knowledge faster than the wisdom it gets to use that knowledge, and that's what I think you have shown in the last slide. Now, there is one question before it can be opened for the audience for the discussion. That suppose you have a metastatic breast cancer patient which is HER2 positive, are you going to use TDXT in the first line?
Not till the data set, we have the trials, and till the data set doesn't come, no, I will not use it. Because, see, we are barely accepting and learning that algorithm. Now, the moment I use TDX, it becomes a gray zone, because you will not have any clinical trial which supports your usage of tucatinib or trastuzumab, pertuzumab combination, and I think it will be making your life also difficult, because what do you do when the patient progresses? In the morning, I have seen a patient, HER2 exported from outside, 4 cycles progressed. So it can happen, I mean, and I was thinking he has taken original drug, everything, but it can happen. Now, if I had used the TDX in the first line in that patient, I would have been totally confused what to do now next.
So I think can I make a comment over here? I think I completely agree with Randeep. A wonderful talk, as always. I think the buzzword today is smart sequencing, right? You have an option of so many drugs, and you know that whatever you do, you're not going to cure the patient. So you have to sequence in the proper way, one by one, and maintain the quality of life of the patient and give the maximum quantity of life.
Randeep, in the last slide, you had shown that patients who get a...
Can we have the slide back in the meantime? Yes, sir.
If we get a PCR, then it's a single agent trastuzumab. Is there a role still for a dual blockade? Beyond
sir, I don't do it. I don't do it. That's why that algorithm I had kept, and not being a very, very scientific forum where you have to really stick. I actually, in my practice, if someone has achieved a pathological CR, see, the whole science evolved over that if you do a pathological CR, the patient will have a better EFS, they will do better. So I actually do trastuzumab as a continuation. Yes, someone who is really having 18-20 nodes, and you know they will not achieve pathological CR. Someone who has a 2-3 nodes and they achieve a pathological CR, especially, and we all know these patients will be majorly ERPR negatives, I may just continue trastuzumab for a year. And as sir said that we have, I mean, it's a chronic disease now. It's a classical chronic disease with metastatic patients having a median survival of 57 months. I mean, even a single diabetic drug will not work for 5 to 6 years. Even many diabetics get changed their insulin preparations in 6 years, and that stops working.
If there are no more questions, we can switch to the next speaker.
Yes, thank you, sir.
Thank you, Dr. Deep. Next speaker is Dr. Nitin Sood. He is the Senior Director in the Hematology, Medical Oncology at the Medanta University, Gurugram. He will be speaking on field myeloma. Nitin, please.
Thank you, sir. At the outset, I want to congratulate Dr. Ved for the launch of this book event. So congratulations, sir, and thank you for inviting me to do this lecture here. Was somebody setting it up? I was listening to the earlier talk, and I must admit I know nothing about breast cancer, but the only thing I gathered was smart sequencing and there's no cure. So that applies for myeloma as well. So with that, I think myeloma is an evolving disease, and there is a need for constant updates in myeloma. We know that we're not going to cure the patients. We know that we can give them good quality of life. We can give them long remissions now, especially with the newer drugs coming in. So it's very important to understand how to sequence those agents, how to maximize the quality of life that we get, how to maximize the remissions, and how to sequence those agents in the sense that how would you rely on the newer agents, especially the expensive ones, the antibodies that have come in, the CAR T cells that are coming in very quickly, and the bispecific antibodies. And as physicians, it's very important that we learn about these, because there are side effects and there are toxicities of these therapies that are new to us, and unless we learn them, we won't know how to use them the best. So myeloma is a disease which is a disease predominantly of the older age group, 6th, 7th decade, the median age is 69 years. We know that NCCN has been around for a very long time, and they develop guidelines from time to time. So I'm just going to give you a summary of those. Is that myeloma is a disease where when you diagnose it, there's no time to be wasted, because it's a disease which causes end organ damage. There's bone damage, there's kidney damage, anemia, hypercalcemia. So you should start treatment straight away, especially steroids if you're still waiting for the bone marrow. And the general dictum now is, unless it's a high-risk disease, a triplet regimen has become standard. And now there's a quadruplet regimen if it's a high-risk disease. And of course, the triplet has to be fine-tuned to the performance status for the frail and the elderly, who can initially start with a smaller dose or lesser number of drugs. And as status improves, they can improve, or they can increase the number of drugs that they use. So there has to be a proper frailty assessment and dose modifications based on patient's fitness. But what about relapse disease? I mean, relapse disease, you're in a worse situation. But when do we start treatment for relapse disease? That's a matter for debate. But it's generally the indications for treatment remain the same as they remain for upfront treatment. So it's also based on the context of the relapse. So there's the serological relapse where the patient gradually relapses, or the frank relapse where there is end organ damage. The treatment depends on what kind of agents you've used upfront. If you've got a longer remission, then you can use the same agent again, especially if you've got more than 6 months. But if you've got a shorter remission, then newer agents, especially newer classes of agents, should be used. Transplant, of course, is considered standard for first-line treatment. So you should try and avoid exposure to myelotoxic agents where the stem cell reserve might go down. If you can't do that, then consider harvesting the stem cells early on, especially before LEN or DARA exposure. The DARA exposure not so much, but if you've got the patient on LEN, then of course you should try and get the stem cells in early. We can always try to preserve the stem cells if you're going to delay the transplant. So again, generally, we used to use intravenous bortezomib, but now subcutaneous once a week is pretty much standard. Carfilzomib, we've been learning, and we now know that twice weekly, once weekly is pretty much the same. Subcutaneous daratumumab is coming in, which we should have access to very soon. So that's the other thing that's going to be a big update, at least for Indian physicians. Steroids doses can be modified. And now a few things to know about the monoclonal antibody. We don't have access to isatuximab, but daratumumab can interfere with serological testing. It can cause false positive Coombs test, but it can also cause a false positive M spike. Especially if the M spike is IgG kappa, then you've got to worry about whether you've actually got the patient in remission or whether this is just the monoclonal antibody showing in. Some of the agents can be potentially cardiotoxic, especially carfilzomib, and of course tend to avoid agents which can cause damage to the stem cell reserve. So these are the agents which can be used, and generally the relapse is now classified as BOT refractory or LEN refractory or intolerant. And if it's BOT refractory disease, there's a long line of category 1 agents that you can use. If it's LEN refractory, equally long line. And generally we tend to use at least either carfilzomib or daratumumab based regimens. For LEN refractory, we've got again daratumumab being a very good drug. Of course, you can use the other agent, bortezomib in case of LEN or lenalidomide in case of BOT refractory patients. So this is what NCCN suggests. If you've got relapse or progressive disease, ideally put them in a clinical trial. And we have access to a few clinical trials at the moment. If you've crossed a certain threshold, especially with transplant, which is about 18 to 24 months, you can repeat those forms of therapies, especially autologous transplant, consider allogenic transplant, and of course coming in our CAR T therapies and bispecific antibodies. So these are the ones that are for relapsed refractory disease who've had 1 to 3 prior therapies, dominated by carfilzomib, monoclonal antibodies, various combinations of bortezomib, lenalidomide, pomalidomide, and daratumumab. So 5 main agents that we've got at the moment. But what you do if you've got pentarefractory myeloma. So pentarefractory myeloma is now defined as myeloma which is refractory to a monoclonal antibody, at least 2 bortezomib or 2 proteasome inhibitors, and both the IMiDs that we've got access to. And 2 of the CAR T products are now approved. The first one is ciltacabtagene, and the other one is idacabtagene. Both not compared to each other or not compared to other lines of therapy, but they're roughly in a pentarefractory setting giving us overall response rates of about 60-65% with CRs of about 30-35%. So which is not bad in terms of heavily pretreated population. Some of the bispecific antibodies are very exciting. The Pfizer product elranatamab, and we've got access to some of the magnetism trials, especially the ones that are looking at MRD negativity for myeloma. The TalTech project or talquetamab, which is so talquetamab is monumental and teclistamab is majestic. So we've got access to majestic in certain relapse settings, at least in the context of a clinical trial. And some of the other older regimens are bendamustine various combinations, but we don't tend to use them anymore. So how I miss the old days? I mean, look at this list now. This is the summary of, this is the regimens that you can use in a relapse setting. There's a huge list to go through, but the general principles remain the same. So if you've got PI refractory, go to IMiDs, and if IMiD refractory, go to back to PIs, and generally use an anti-CD38 antibody. So here's the evidence of why they should be used. These are the regimens for BOT or LEN refractory. So in general, daratumumab or carfilzomib with dexamethasone, and this combination shows a deep response or deep or longer progression-free survivals. Isatuximab we don't have access to, so I'm not going to go into that. You can use CAR-POMDEX, which used to be fairly popular, but as more agents have been available, CAR-POMDEX has fallen off the radar. Dara-Pom-Dex, the Apollo trial showed that in Len or bot refractory, this regimen works well with good progression-free survival. So again, I'm going to skip this. What about Len refractory regimens to be used? What is the evidence for that? So Dara-Len-Dex, the Castor-Pollux trials, the original ones done in 2015-16, and then so this is actually results from Maya, which shows that if you add Dara to Len-Dex and Len-Dex only, compare it to Len-Dex only, then you get a deeper response, a longer median follow-up, longer progression-free survival and overall response rates. Aspire showed Len-Dex works versus Len-Dex on its own. What do you do if you've got bot refractory disease? Len refractory disease, bot can be used. So Dara-Bot-Dex in a phase 3 trial. Pom-Bot-Dex again in a phase 3 trial, and Selenoxor is not relevant to us. Selenoxor is, by the way, fallen off the cart for some reason anyway. What about bispecific antibodies? So elranatamab, Pfizer molecule, is being investigated, and magnetism series of trials. So most of our evidence at the moment comes from magnetism 3, which is a phase 2 trial, and looked at subcutaneous elranatamab once a week in 2 different doses, and it's giving us an overall response rate of about 60% or so. Penta-refractory patients, so 30% CRs, not bad. But we are also investigating elranatamab in the post-transplant maintenance setting in the Magnetism 7 trial, and the Majestic group of trials looking at teclistamab, which is the anti-CD, so BCMA anti-CD3 bispecific antibody. And again, overall response rates in this heavily pretreated population of 60-65% with about 40% CRs. So, no talk on relapsed refractory myeloma is now complete without CAR T cell. And the Siltacaptogene autolysel, the first CAR T is not being compared to each other or bispecific antibodies yet. But these are the ones, heavily pre-treated population. As you can see, they've received at least 3 or more previous lines of therapy, including IMiDs, including PIs, including the CD38 antibodies. And for some reason, the overall response rate, highly selected population, but response rates of more than 90%, with 67% achieving a CR. So that's not bad, but we've still got to wait. And the access to CAR T is through the REMS program at the moment, because the risk of CAR T with cytokine release syndrome and the neurological syndrome of ICANS is still there. So CAR T has to be used carefully. You have to have a big hospital with good critical care facilities, a good neurologist on board who can assess very carefully for ICANS and CRS. And if that happens, then you have to have steroids, IL-6 blockers like tocilizumab on board or on site to make sure that patients don't get deeper into those side effects. So that's the CAR T. We can't miss supportive care when we're talking about myeloma. There's bone disease, so always use bisphosphonates. Bisphosphonates, you have to assess vitamin D status and replace vitamin D. At least 2 years monthly bisphosphonates is the standard of care, and after that we can taper off the bisphosphonates to 3 monthly, 6 monthly, depending on the depth of remission and how frequently can the patient attend for follow-up. And it's a very, very individual decision based on clinical judgment. You need to have an orthopedic surgeon on board, sometimes even a neurosurgeon, depending on where the myeloma end organ bone damage is. If it's the spine, we generally use our neurosurgeons. If it's long bones, then orthopedic surgeons, especially if it's a weight-bearing bone, then you might need to do something to avoid a skeletal-related event. Hypercalcemia, hypocalcemia, both a problem. The hypocalcemia is a problem with bisphosphonates, so make sure that you check calcium frequently and dose modify based on the renal status. Now we've got access to denosumab, but we need to still worry about the calcium. Initially, they might have hyperviscosity depending on what kind of monoclonal antibody, especially, burst with IgM. So plasmapheresis may be needed. We do less and less often now, but with the light chain kill that we get with proteasome inhibitors to start with, is generally enough to not use plasmapheresis anymore. Anemia remains a problem with marrow infiltration, so transfuse. Erythropoietin can be used. Severe thrombocytopenia, in general, bone marrow failure, there can be bleeding, so transfuse platelets. If there is a coagulopathy, then replace vitamin K or give FFP cryo depending on what you need. Thromboprophylaxis is something that we tend to forget very often, and some of these drugs, let's not forget, can also lead to thrombophilia. So thromboprophylaxis definitely needed. Generally early mobilization, but aspirin depending on what the physician and patient preference is. So IV immunoglobulin is the other thing that is expensive, but replacement can save a lot of infections, a lot of chest infections, hospital admissions and stuff like that. So always consider IVIG especially if there is low IgG levels. So that's all I have. Thank you very much for listening, and back to Dr. Agarwal.
Thanks, Dr. Nitin. So any questions or comments, please?
So, Nitin, one question to you here.
Sir.
Thank you for a very, very nice talk. Like if you have a 5-drug refractory myeloma, then would you use CAR-T first or would you use a bispecific first?
At the moment, none of them, because we don't have access to any. We have access to elranatamab in a clinical trial, so we can try that. We're going to have access to teclistamab in a phase 4 clinical trial, so we could do that. But access to a CAR-T in India at the moment is not possible, like outside of a clinical trial setting. Immunil is doing a clinical trial on myeloma CAR-T, BCMA CAR-T. But at the moment, probably teclistamab in a phase 4 trial.
Any other question or comments? Dr. Lalit, will you like to say something? I think if there are no questions, we thank you, Nitin. We end of this CME session and go for the next program.
Thank you, Chairpersons, Dr. Agarwal and Dr. Batra. Now, for the function for which we have gathered today, I would like to introduce our guest of honor, Padma Shri Dr. Ashok Vaid sir. Sir is Chairman of Medical Oncology and Hematology, Medanta, the Medicity. Our chief guest for the function, Padma Shri Dr. Lalit Kumar sir. He has students across the world, across India, and they are occupying the top positions in different institutes now. Sir is ex-chief of IRCH AIMS and HOD Medical Oncology, and currently chairperson of Oncology and BMT at Artemis Hospital. We have today Dr. Dinesh Pendharkar, I would say a globetrotter on one side, and on the other side, all villages. He would not have left any village in India for oncology. He is chairman of National Cancer Society, past president Indian Society of Oncology, ISMPO, and past chair International Affairs Committee of ASCO. We are very fortunate to have Dr. Professor Ahmed Malhotra sir. He is Director Oncology Services at Shri Ram Cancer Center and Super Specialty Center at Jaipur. He is former professor and head Department of Medical Oncology at SMS Hospital, Jaipur. And he has also authored a book which is going to be launched tomorrow during Epicon at Delhi. And one more stalwart with us, Dr. Purvish M. Parekh. Sir is ex-professor and head of Department of Medical Oncology from Tata Memorial Hospital, currently working as professor and head clinical hematology at Mahatma Gandhi Medical College and Jaipur, and he has many hats to his credit, establishing ICON, and he has been a thorough teacher and so many students across the world. Welcome, Dr. Parekh. So I will request first to Dr. Yeah, and along with the guest of the evening, I would request our chairpersons also to come over and release the book first, and then Dr. Ved will say something about the book. Please, sir. जी सर हाँ हो गया सर हाँ so I would request in the meantime I would request Dr. Ved to say a few words about the book.
Good evening, ladies and gentlemen. A very warm welcome to everyone present in this hall, and also a very sincere and an equally warm welcome to all those who have found time to join online. And I learn that the number is going to be close to 1,000. That speaks volumes about the hard work put in by the organizers, particularly Mr. Rajesh and Mr. Rakesh from Get Well Pharma. This book has a little history to it. We were almost prepared in the year 2020 to release it when COVID struck. And I must thank Mr. Manas Tandon, who's the owner of Get Well Pharma, carrying on the legacy of his illustrious father, Mr. Rajiv Tandon, who was not only a very successful entrepreneur, a very excellent chemistry guy, and had been doing a back-end job, and a good friend of mine. The idea actually came across during one of the meetings, and we went on putting the book together. But unfortunately, due to COVID, we couldn't do it, and we had to do a lot of work over again, because as you heard through these two lectures, how quickly science is changing. And the pace at which it is changing, we need to change. So we almost had to do the book again. And then there we are today, having the physical form in our hand. And I'm honored and privileged, sir, Professor Lalit Kumar. You've been a mentor and a teacher. 30 years back, I was a student with you. I was a part of the first bone marrow transplant you did, a myeloma, interestingly. And one can well imagine the infrastructure and the facilities available 30 years back. And then the presentation of those 6 myelomas in the first meeting held in Delhi. And that time it was not the ISMPO, it was the Indian Association of Cancer Chemotherapists. So it's been quite nostalgic and a long journey, but you are a teacher and a mentor to generations of oncologists spread all over the world. Thank you so much, sir, and it's my honor to have you as the chief guest today. There are other friends of mine, Dr. Purvesh, Dr. Hemant, and Dr. Pendarkar. Ladies and gentlemen, that's not their qualification to be here, not that they are my friends. They have been the movers and shakers of oncology over the last few decades, seen the paradigm move, seen the survival curves go up, and we have seen the survival curves go up to a point where we have declared some of the cancers as cured, almost cured. I remember Purvesh you showing one of the slides on ALL, and that's a bit of a nostalgia for me because my thesis was on ALL, and that was on two different eras. Sir, you taught us Holzer's consolidation for ALL, gone past. And they were the two different time frames when we were doing the earlier protocols, whatever it was, and then came the MCP 841. And there were 174 cases in my dissertation, out of which 101 were on MCP 841, and one could see the survival curve go up. And many more diseases where there was a extreme nihilism. We had nothing for renal cell, metastatic NSCLC. The list is long. Today we have robust answers. Patients are living longer. Quality of life has gotten better. And as already stated by Randeep, that the median survival for a metastatic breast cancer, HER2 new positive, has gone into years now. Now this is how oncology has changed, and these are the gentlemen who have seen this change. They moved the paradigm, and that's why they are here. I'm privileged to have you as special guests on this occasion. Science is changing. We have this book in the physical form, and Mr. Manas Tandon has been very gracious to agree to the fact that we put up an app and also do the next edition on the app in different sections so that we could have more inputs, involve more people and more thoughts in bringing out a better product. And keep the whole thing very contemporary and up to date. We know that in our busy practice, if you punch a word, single word for a treatment of metastatic HER2 new positive, you just cannot choose the protocol. It's our endeavor to stay contemporary, as I said. Also, not to forget that we are in a resource-deprived part of the world. Everybody cannot afford immunotherapies or targeted drugs. So therefore, the chemotherapy or the cytotoxic combinations are still relevant, not only from the standpoint that many cannot afford those drugs, but also immunotherapies need to piggyback the cytotoxics still. So this book would be a great reference point for all of us to refer back to, and I promise we would keep it very, very updated and contemporary. I close out here by thanking Getwell Pharma, Mr. Manas Tandon, Rakesh, and the other team at the back end who spent hours and hours going through the manuscripts, making sure that everything is looked into, spell checks, everything is in order, and the references are updated and they are relevant. My sincere and special thanks to everyone. They put all the resources very readily available for accomplishing this job. Once again, thanks Professor Lalit and my friends out here, those who have attended online and those who are out here in this hall to attend physically this evening. Rajesh Sharma, always your hard work is what brings the best out of every function. Thank you so much. Last but not the least, the support of my family. It's always there. Tanishtha, Tejaswini, and Sabita. Thank you so much once again.
So the team is ready. They were about the sequence. So please bring the book. I request Professor Lalit sir, Dr. Parekh sir, Dr. Pendharkar sir, and Dr. Malhotra sir to come over. Along with that, I would like Dr. Sabita madam to join. Miss, yeah.
So we have, for the ease of practicality and the use, there are 2 volumes. The solid tumors and the hematology have been separated out. I hope it would come handy.
I request Mr. Manas Tandon also to join. And just to inform the online audience, we have on the online portal there is a request form which you can fill up to receive the hard copy of the book. So far we have already received 600 requests for getting the hard copy. We have a small Thank you everyone. Now I request Dr. Lalit Kumar sir to say a few words of wisdom.
Well, thank you, Dr. Ashok, and thank you, the organizers. This is I would say, like heartiest congratulations once again to Dr. Ashok and the team who have been able to compile. In fact, when he wrote that Handbook of Cancer Chemotherapy, I remembered my earlier days and some of our seniors who may have seen. We used to have, when we were starting our career in oncology, a lot of people from pharma will bring some of those booklets kind of things, some protocols written and all that. They will hand over to these and people will keep on going through some of those. So, but this is really kind of quite, so This is like having this chemotherapy thing. So, I mean, it's called chemotherapy, but now you have so many things like targeted immunotherapy and antibodies and so on and so forth. So this is just a kind of a Bible for any medical oncology people or oncology people, community. That to have these things handy, you can just refer it and go through like if you suddenly find something new. And Dr. Ashok, I have known him for last 3 decades. I've seen him really, and so this is really a big accomplishment, Ashok. And once again, heartiest congratulations. It's a daunting task to really able to write this much of amount of thing, put it into this, and I was just really hoping it will be something like a small booklet which I can keep in my pocket. So this obviously cannot, this has to be like on your desk or something which you can really go through it. So this is a huge, huge amount of work and really appreciation for that. And lastly, like to congratulate all of you who are here to witness this historic thing by one of our colleagues who has been in the field, the huge amount of experience, maturity, able to put up his thoughts so that it can benefit all. And also the people who are online, really by thousands of my colleagues who are seeing this, I'm sure it's going to be helpful. Most important would be like if you can really give feedback to the author about the book, the different chapters, the components, that something which need to be updated, need to be improved upon. That will be, I think, the great service which all of you can do that to him. Thank you so much.
Thank you very much, sir, for your kind words. As you rightly said, it takes a lot of work to get such a voluminous book. We have been seeing these cancer chemotherapy handbooks in that era. It used to be in pocket and like that. And it is almost impossible to concise everything like Gagar mein Sagar Bharna. I attended one of the presentation of Dr. Parekh couple of years back where he has said that there are 96,000 publications coming all over the world. I remember that. So I don't know how much are coming now. So with this, I would request Dr. Pendharkar, to say a few words.
It's really an honor and a pleasure to be here. My heartiest congratulations, Ashok. Great job done, required, and it's matter of pride for all of us because ultimately you are one of us. So I'm sure it's a big credit to an oncology community, to medical oncology community. Writing is extremely difficult. If you have to write one article, it takes months to write, not even a day. And majority of the time, we don't finish the articles. So if you have done this, it really deserves a great applause, and we are all with you. But as I say, it's our pride. We are really happy that you have done it, and it's good for all of us. Once again, congratulations.
Thank you very much, Dr. Pendharkar. Now I will request Dr. Purvish Parikh sir to say a few words.
Thank you very much for this opportunity. I don't want to say anything about the book. I will say that after I have read it. But I want to share a little story, and if that story's ending was different, then we would not be sitting here and the book would not have come up. So Ashok is there, Sabhyata is there, daughter is there, and we were all, in a boat sailing from one island to the other when the tsunami passed under us. Okay? The tsunami passed under us, the boat went up and down, and we were safe because the boat was far away from the land. Tsunami wave comes up only when the land is nearby. And at the resort that we were staying, there was another Japanese group who had gone scuba diving, and they were never found after the tsunami. So Ashok, Sabhyata, Vaid family, it's proud privilege to be here, alive and celebrating your book, just because God has been graceful to us. Thank you very much.
Thank you very much, Dr. Parekh. I am picking up one word from your speech. We have a tsunami of cancer information and research and solutions coming out for cancer care and cure. With that, I would request Professor Hemant Malhotra sir to say a few words.
So good evening everybody, all of those who are physically present here and all of those who are virtually present with us. Like a huge privilege and honor for me to be here, and Ashok, apologies for gate crashing on your party. I've known Ashok for more than 30 years now, and maybe a few years senior to him, and he's always been an exceptional human being and an exceptional oncologist. Dr. Parekh and myself, we've just finished writing a small book, like a handbook done under the auspices of the Association of Physicians of India, Oncology for Physicians. And I don't know how, we almost both of us went crazy in compiling and getting it ready. And if it hadn't been for Dr. Parekh's patience and persistence, I would have just, dropped the idea. Do realize how difficult it is to go through the process of writing a whole book. And I remember when we were residents in oncology at Tata Hospital, we used to read those foreign handbooks. In fact, I remember passing my ESMO medical oncology certification exam just by reading one of those handbooks. And now we have our own handbook written by our own expert, and I think it's going to be incredibly useful not only for students but also for faculty. And as Dr. Lalit always gives you the best advice. It will be the biggest service to Dr. Ashok and to the editors of this book if all of us could give him feedback, send him a WhatsApp message or send him an email that this I think is an error in the book and this I think is lacking in the book. That will make the next edition so much easier for him and so much better for all of us. So congratulations again to Ashok and his team for this incredible effort, and I'm sure that this is going to be I don't know whether you're going to make money out of it, but it's definitely going to be a blockbuster. Thank you very much.
Thank you very much, Malhotra sir. Now I request all guests to come, and it's time to facilitate. I request Mr. Manas Tandon and Mr. B.M. Sundaram from Getwell to come over. And first I will request Dr. Lalit Kumar, our chief guest. Thank you, sir. I request Dr. Vaid sir. Thank you, Dr. Vassar. I request Dr. Dinesh Pendharkar, sir. And I would request Rakesh ji to come over. Dr. Parekh sir and Dr. Hemant sir. Manas ji. And Amit. Dr. Malhotra sir, Manas ji. Thank you very much, Dr. Malhotra sir. I request chairpersons, Dr. Agarwal sir and Dr. Batra. And our faculty for the evening, Dr. Randeep Singh and Dr. Sood. Now I request Shri B.M. Sundaram, Chief Strategy Officer, Getwell Pharmaceutical, he will talk on Zoom into the global future plans of Getwell Pharmaceutical. He will be responsible for driving business into various regulated markets. Mr. Sundaram, popularly known as BMS, he has experience of 35 years of long journey in global pharma markets. He has launched and established top oncology companies from India into many countries across the globe. Mr. BMS, B.M. Sundaram.
Respected doctors, good evening. A warm welcome from Getwell Oncology. First of all, I would like to thank everyone for your valuable presence. As you know, Getwell is dedicated in the field of oncology for the last 4 decades. Today, we are in the process of strengthening our presence in India. At the same time, we are expanding our footprints in many parts of the world. A state-of-the-art manufacturing unit has been commissioned recently in Bawal to export our oncologicals to regulated markets like USA, UK, EU, Australia, Canada, so on and so forth. During this process, we shall be harmonizing our product development and manufacturing for all markets under one umbrella under one global quality management system. Our global manufacturing unit will focus on only one aspect, one global quality across the world. India is, of course, one of our primary markets. In the near future, we shall be launching innovative products, biologicals, and support therapies. We are in the process of strengthening our R&D unit, and efforts are on actually to strengthen the complex delivery systems like pegylated and liposomal forms. Last but not the least, we shall continue our efforts in the area of continuous medical education and patient education efforts through eminent oncologists across the country. Looking forward to your patronage and guidance. Once again, thanks for your valuable presence.
Thank you, Mr. Sundaram. He has been senior to me in Dr. Reddy's lab. Now, I would request Mr. Manas Chandan, who is Managing Director and CEO of Getwell Pharmaceutical. He has 15 years of experience of managing a large global pharma company, or in fact giving a shape to it of a global pharma company. With his own world-class manufacturing facility, they are coming up with a second one with reliable and affordable products. He is credit of establishing the company in so many countries. He is proposing the vote of gratefulness. Thank you.
Yeah, once again, very good evening to all of us, all of you. On behalf of Getwell Pharma, I would like to express my sincere thanks to each one of you who have been present here and who have logged in online live to this event through several other platforms. To begin with, I would like to use this opportunity to thank my late and beloved father, who has been a visionary leader in conceptualizing and envisioning what Getwell is today. And in fact, as Dr. Vaid mentioned, this whole book had been his dream, and collaborating with Dr. Vaid was another of his wishes that we should come up with such a valuable resource. So, though sadly he's not here anymore, but I'm sure he would be blessing us all and hoping for this journey to continue ahead. Moving on, I would like to thank my sincere gratitude to Dr. Lalit Kumar. In fact, sir, you have not been inspiration to many oncologists, but to also several pharma professionals. During our college days, we used to actually meet you for our project purpose, and I still remember you treating us to a cup of tea in your house in Ames. So thank you for gracing this occasion. It's a kind of a fanboy moment for me seeing you here today. I still remember our discussions on the values you used to provide us during those tea chats. Moving ahead, I would like to express my deepest gratitude to Dr. Vaid. And without his contribution, this conceptualization, the whole creation of this valuable resource would not have been possible. In fact, I would also like to thank for his patience and time he had been giving to our team, who used to, every now and then keep bothering him with lots of edits, lots of going back and forth on the texts, on the chapters. I'm extremely thankful to Dr. Vaid for giving his valuable time in developing this resource. Going forward, I would like to express my sincere thanks to our special guests, Dr. Dinesh Pandakar, who have traveled, Dr. Hemant Malhotra, Dr. Purvish Parekh, who have traveled specially to be a part of this special occasion and making it more memorable. Going forward, I would like to thank Dr. Randeep Singh, Dr. Nitin Sood, Dr. Sandeep Batra, Dr. Chaudhary in contributing this CME and sharing your insights on the various aspects of multiple myeloma and HER2. I'm sure this event would have been, a good contribution to the overall learning of the fraternity. Well, last but not the least, I would like to thank my medical team, who has worked hard over the past year in making this happen, and bringing every one of us together. I would also like to emphasize this is just the beginning of several initiatives which we have in pipeline, and we would like to seek your guidance every now and then, to take your contribution every now and then, to bring up with the best possible resources that can help the fraternity. So once again, thank you so much from my side, from Get Well, and thank you for gracing this occasion and coming on a Wednesday evening. I know it's not been easy, but we are so glad and grateful for the crowd we have able to gather. Thank you so much, sir.
Thank you, Mr. Tandon. Your father has been stalwart in oncology. We used to get inspired from him. And for the online audience, before you log off, do not forget to post your request with the address and all for getting this handbook. I am sure I am on the camera and the book is visible. And those who missed this logging in their request, they can contact the Get-Well representative in their own area. Thank you so much. And with that, I invite all of you for join for dinner.